everyone, and welcome back to They Say It Takes a Village. Before I get into today's podcast with my esteemed guest, I wanted to give a huge shout out to the incredible people at Wear That Now who actually dressed me for today. If you are anything like me, going to the mall is absolutely anxiety filled. The parking, throw in 2 kids, a busy schedule, just to find an outfit for a particular occasion. Well, Wear That Now has literally come to my rescue. Obviously, this podcast is recorded and I've ran out of clothes to wear. So what they've done is they've teamed me up with an incredible stylist who has her finger on the pulse and knows exactly the likes and dislikes that I want. She had put together a curated outfit to be able to showcase it here today. So if you guys are anything like me, check out Wear That Now to get teamed up with your very own personal stylist. And if you don't even have enough time, they will send you a curated box of all of your outfits to fit any budget for any occasion. Check them out on their Instagram, which is at wear.that.now. Send me photos of your outfits and I can't wait to see it. Joining me today is a man who needs no introduction whatsoever. He is the leading expert in fetal medicine and high-risk pregnancies here in the UAE and globally. He is also the mastermind of the world-class clinic, Genesis Healthcare. Hailed for his unwavering dedication and expertise with his patients, Dr. George Michailidis is here with me today to do a deep dive on 2 areas that are not very well understood: intrauterine growth restrictions, or IUGR, and preterm deliveries. Dr. George has been at the forefront of research and clinical practice to try to deliver the best outcomes for these situations for his patients. So without further ado, Dr. George Michailidis.
Very good morning. Lovely to be here.
Good morning. Thank you so much for being here. This is an absolute honor. Thank you for being here. Dr. George, I usually start by asking, obviously, a little bit about yourself, but I think I just wanted to ask, how long have you been practicing here in the UAE?
We came in Dubai in 2009, so we're coming almost to 14 years. Some of the first babies that we delivered, now they're big boys and girls. Yes, which is lovely to see them growing.
Yeah. It's wonderful. I'm thinking in your lifespan, it must have been countless deliveries and countless babies you've brought into this world.
Which is true, but each one of them is so special.
Absolutely.
Yeah? I think as in the different fields of medicine, being an obstetrician is such a great privilege to have that unique moment in the family life.
Absolutely.
Of delivering a baby.
Yeah.
Kind of the way that you see a mother glowing when she looks at her little one. There's nothing like that.
It's so lovely that you say that, because a lot of the times that's exactly what you're looking for as a mother, to have that type of connection with whoever's looking after you, you know, for the person who is looking after you to have so much, I would say, again, dedication to you and your pregnancy and your baby. It's a wonderful thing. And, you know, I think I speak for all the moms who've been under your care. Everyone is super grateful to have your.
It's a privilege. It's a privilege.
Today, I guess we're talking about 2 areas that are a bit confusing and I think a lot of the time quite anxiety driven. The first I'm going to start with is obviously IUGR, or intrauterine growth restriction. Can you give us a little bit of a definition of what exactly is it?
It's interesting that you say that is confusing, because even within the medical profession, we struggle to give definitions on what is intrauterine growth restriction, or IUGR. So globally, if you are to take an academic view, if either the baby's size, the estimated fetal weight, or the abdominal circumference, when we do the ultrasound measurement, is less than the 3rd percentile for the gestation, this is considered a growth-restricted baby.
Okay.
But out of it, there are a lot of strands. And how do you define which chart, which gestation? So going a step back when you're looking at a pregnancy, and this is a common problem, especially where we practice there, the very first step is setting the dates correct. When is your due date? when are you going to be 40 weeks? And a lot of times when you chat with mothers, they say, it's December time. Okay, but this is not narrow enough when you try to work out at weeks. So normally the best time to determine the gestational age is when the woman sees their obstetrician the first few visits, 8, 9, 10 weeks, because at that point, all little ones are roughly the same. So whether this baby is going to be a big person or whether it's going to be not such a tall person, still we are the same. So the accuracy of those scans is about 4 or 5 days. So it is very important for this to be determined and even more documented. The other thing that, as you know, happens in private practice, people change. They fly from one place to the other.
Correct.
They change from one obstetric provider to another. And many times the actual records are lost. So it is important both for us as care providers and for the mother as a mother record keeping to determine when is the due date, because that's a point of reference. This is what you are using to go back and say, this baby is growing well.
That's correct.
Or is not growing well.
Yeah.
So coming back to your question, third percentile, it's a universally accepted definition of a growth retarded baby.
Yeah.
But is every small baby abnormal? Not really. Some of us are big, some of us are small. Yeah. So there is a number of other layers that are coming into play and distinguishing between IUGR and small for gestational age, meaning a constitutionally small baby.
Okay.
A very simple example. You have a mother who's 2 meters tall. She's expected to have a baby that is going to be above average following the mother's side. You have a mother who's very petite herself. She's 150 and 48 kilos, yeah? Do you expect her baby to be on the average? No. It is most likely going to be following mother's side. So you will find it on the 10th, 5th centile. So it's not only the size, but it's also how the baby is growing over time, which brings us to the next thing, which is the growth trajectory. If you see on the reports from the ultrasound scan, and again, it is important for things to be recorded and be given out to the patient, the client, you will see the charts. And it's very important with those charts to actually graph the different scans. And that's where you see how the baby is growing over time. So again, if you were to go back to the academic definition, IUGR is a baby that drops 50 percentile between kind of two scans. Yeah. So let's say one day you are measured on the 70th percentile, and a month later you drop to the 20th percentile. So obviously this baby did not grow during that period of time. Mm-hmm. So summary, small babies can be universally small. Definition of IUGR less than the third percentile for the gestation. Okay. Quote, gestation needs to be accurately calculated. You will find other lines. Usually statisticians want to use the 5th percentile, the 10th percentile, but usually these are flags rather than definition of IUGR. Okay. These are limits that you start looking at things a little bit more carefully. Mm.
So let's say, for example, I mean, you see women, I guess you see mothers on a monthly basis. In terms of diagnosis of IUGR, to go back to that a little bit, is it that you just notice that there is no potential growth that month, and then you will then observe over a certain period of time? I mean, in terms of giving a definitive diagnosis, how would you go about doing that?
depends on how the mother presents to the clinic. So you will have, at least in private practice in Dubai, two groups of mothers. The mother that follows with a specific obstetrician, and that obstetrician is measuring whichever way they measure the baby's growth, and they would be the one saying, your baby is not following, it's a little bit smaller. Let's see you in 2 weeks' time. Actually, now I'm starting getting worried. Yeah?
Okay.
So you see the growth trajectory kind of falling off. And normally these obstetricians then, they will refer to whoever fetal medicine specialist they are working with to get a much more detailed assessment of baby's condition.
Okay.
That's one scenario. The other scenario is that you just come routinely for your 30-week scan.
Yep.
And baby looks small. Yeah. Now, other than the size, there are a number of other variables that the clinician would look to try and differentiate between a normally small baby and a baby that it's not growing well.
Okay.
The ones that are more commonly understood is the amniotic fluid, the water around the baby, or how is the blood flow from the baby to the placenta, or how the baby is distributing that blood within its system. It all has to do with the adaptations that the baby has to do when the placenta is not offering enough. Yeah. So what the baby will do, just talking about the amniotic fluid, it does not need its kidneys. This is our amniotic fluid is our wee, effectively. Yeah. So placenta is doing all the work, says, actually, I don't need my kidneys at this stage. Let me shut down and conserve energy. So kidneys are shutting down, less amniotic fluid.
I see.
Let me just make sure that I want to grow my brain. Yeah? Let me just make sure that I'm sending more blood to my brain.
Almost
because
redirects the priority.
Exactly.
Yeah.
So this is called redistribution. So you see from the blood going to the placenta, increased resistance, not so much placenta working, fluid going down, blood flow to the brain increasing. So these are all subtle changes that happen over time that normally the clinician who is assessing this baby is trying to put together in order to set a plan of action following up. How much are we worried? What is going to be the follow-up?
As opposed to it just, like you said, being small genetically, or, it has a small predisposition due to the parents.
Now, if you use, let's say, the 10th percentile as calling them small, by definition, 10 out of 100 women will be small. Yeah. This doesn't mean that they're abnormally small. Absolutely. They need different action.
Yeah. So I think it's a matter of looking at the overall picture.
Absolutely.
and then potentially coming up, like you said, with a plan of action. I think what it is, a lot of the times the graphs might be a bit confusing, of course, to patients and things like that, because you do see a clear line of the percentiles. And so there is a worry when you see any variation of either that middle or the top.
You are spot on that.
It's just a very big cause of concern.
Every mother wants the baby to be absolutely on the 50th percentile.
Absolutely.
And
that's what that's where your eyes go to.
Yes. Yeah. And you get very worried about it, understandably. And it comes to the clinician part to actually explain.
Don't go to Dr. Google.
Well, we cannot escape from the time that we live in. You will go to Dr. Google. There's no chance that you will not. The clients that we are looking after, you are intelligent ladies, you are educated ladies. You will definitely go to Dr. Google. Now, the role of the clinician is try to direct you to the correct resources, and from the information and the worry that you get from Dr. Google to actually distill it to what is relevant to you and to your baby. And the next level is the level of confidence that you have to what I or the clinician is saying. And again, this is a very beauty of private practice. If you manage to build up
that relationship,
relation and confidence, and you relay that information without dismissing mother's worries, it's more likely that you will achieve the aim in terms of explaining. It doesn't mean that you will completely reassure them. A mother will always be a mother. She's always going to be worried. Yeah. But at least give her a line of thought so the intelligent brain can follow.
Absolutely. This might be a fully loaded question, but I mean, what are the potential causes for IUGR? It's a huge question.
It's a huge list.
The reason why I ask, a lot of the times, I guess, again, speaking as a mother, and you've got this responsibility of carrying a child. So a lot of the times what you hear is mothers almost internalizing it as if it is something that they have possibly done. And I feel that should be kind of addressed because it may not be the case at all. And that's why I feel, yes, there is a huge list of reasons why you could potentially be in a situation where there is a growth restriction. So that's why I'm asking. Yeah.
That's a very interesting question. And I think the reasoning and what you do very much depends on the type of population that you're dealing with. And we are exceptionally lucky kind of here with the group of mothers that we look after. So if you look globally, the most common reason for growth retardation are things like malnutrition. You don't have food to eat. Things like anemia. You're eating something, but in terms of quality of food is not there, or you have 5 other children that they came one after the other. Infections, things like malaria. Yeah. This, if you look at it on a global scale, these are the main reasons for growth retardation.
Yeah.
Do any of these things apply in Dubai? In our, at least the clients that we see in the main hospitals of Dubai? Probably no. If you go to the next level of bad habits, kind of low socioeconomic part, but not only that, heavy smokers, heavy drinkers, drug abusers. Again, this is not a population that we usually look after here in the private sector.
Yeah.
So these are big groups of correctable causes, that, yes, they're there, but they don't apply to the women that we look after. Yeah. So then what you're left with a number of causes that really you have no control. Some of it is genetic.
Yeah.
Some of it has to do with maternal illnesses or conditions. For example, things like lupus, autoimmune diseases. Yeah. That can affect how the placenta is interacting with the mother. And there is a big group of growth retarded babies that we don't have a specific reason to come up with. So again, closing the loop and going to your initial point, which is very important, is taking the guilt away from the mother.
Yeah.
Kind of explaining that this is what's happened. You've done nothing wrong. And in most cases, there's nothing that you can do different to actually correct it.
That's correct. Yeah.
Because a lot of moms will say, well, okay, I can see this baby is small. Do I really have to eat more? Is it my diet?
That is something that people will think about.
It is a question.
Absolutely.
And the answer is absolutely no. Yeah. So unless you were starving, which our mothers normally don't starve, how much you eat doesn't affect the baby. It all has to do, I think the simplest way of thinking about it is it's how the plug is interacting with you, so how the interface, the placenta, is actually taking nutrients from you and passing them over. That makes a difference rather than how much the mother is eating. So the mother can do very little to correct it. The next question, other than food, is, George, I'm stressed. Or usually the woman doesn't say that, but her husband says that, yes? Says, she's stressed all the time. And my usual approach is, we never say to our wives, to our clients, to don't stress.
Yeah. Because chill out. That's never going to be a statement.
Not even that. We just live it. We talk about something different.
Yeah.
Because once you say to somebody you're stressed and you connect it with the condition of the baby, they stress even more.
1,000%, without a doubt.
The idea is the linking. We cannot put ourselves in a little glass box. Things are happening around us, whether this is relation, whether it is business, whether it is other children.
Yes.
We are going to be stressed. Yeah. So it's not an issue of saying don't stress. That's leave it around. The idea is try to calm the husband down and focus to the mother. However, there are some elements for the professional lady that she might be able to change. Again, in general, the group of mothers that we look after, they tend to be high achievers. There are women that they want to do everything perfect. Pregnancy is in a way a project. Yeah?
Yes, 100%.
In a good way.
Yeah.
However, there is that conflict between the pregnancy and the working environment.
Yeah.
And things are changing in Dubai, but in here, like in many other places, it's like a man-dominated part.
Yeah.
So for a lady, a professional lady, to be able to advance where she's going, she needs to do a number of sacrifices. And that's when the conflict says, I need to do more because I'm pregnant and because I'm going to go and because
you have
everybody...
something to prove. Yeah.
Exactly.
Yeah.
So again, trying to readjust focus from the mother, from the stress, but at the same time, managing your time. I always say to mothers, enjoying, it's not always the right word for pregnancy, but giving it the right value.
Or embracing it, embracing it for this phase of life. Yeah.
Giving value. Again, it's probably my male brain kind of working on project management, but it works with professionals. It's seeing where does your pregnancy stay, what is its position in respect to everything else around your life. Yeah. Because if you manage to give it the right value, then your actions will follow, kind of looking at this pregnancy. So we have stress, we have diet, physical activity. Again, we want our mothers to be in general active. Yeah. Again, if you look worldwide, if you take a mother out of the factory, if you take them out of the field, those kind of extreme
labor intensive,
you will have an effect on the baby. For us, it goes more on the elite athletes or a lot of people that are very much, the semi-professional athletes may not be competing,
but so push the boundary of physical exertion.
Exactly. Yeah. So this is another thing that they can potentially do.
Yeah.
And the final thing is just setting alerts. Our best monitoring part for how a pregnancy goes is the mother. You know your baby. You remember in your pregnancy, you know how your little one is behaving. You know over time its pattern. So making clear to them that this is what they need to be keeping an eye and giving an open access to them to reach out, whether it is the hospital, the clinician say, hey guys, I'm worried.
Something doesn't feel right.
Doesn't feel right. Yeah.
I feel you've answered that question because I was going to ask you about lifestyle and, lifestyle potential modifications. And I feel that actually is perfectly explained. I feel like now, let's say, for example, if somebody listening to this, what would be, if to have let's say, a mother has gone in, what would it look like if you have suspected potential growth restriction in terms of how many times would she come back in for scans and monitoring? I mean, what does that look like in the course of the pregnancy?
Depends on the gestation.
Yeah.
Depends on the severity.
Okay.
Yeah. And again, the beauty of private practice is that we can see a mother
As
many times as you want.
Yes.
And that's in inverted commas, because obviously there's always the financial constraint.
Correct.
But the good thing is that most of the clinicians practicing in Dubai, they have quite a significant control on the charges. So you can adjust. Yeah. And at the end of the day, what makes a difference is the health of the mother and the baby. Yeah.
Yeah.
So how often would you see? The normal care for a low risk mother would be seeing your doctor roughly on a monthly basis, pretty much up to 28 weeks, and then every 2 weeks up to 36 weeks, and then weekly till delivery. Yeah. Now, depending on the time that you pick up the problem, you adjust the frequency of visits, because the game that the clinician is playing, what he's trying to determine at any one point, is where is the better place for baby? Is it being with mom?
Yeah.
Or is it coming out
Yeah.
and dealing with it? Yeah.
I guess that brings me to my obviously next huge question, which is preterm. A lot of the times, obviously, like you said, IUGR potentially may result in preterm deliveries. I feel they do go hand in hand, if I'm not mistaken.
Yes, for different reasons. IUGR will bring up what you would call an iatrogenic preterm delivery,
Okay.
as opposed to the biggest part of preterm deliveries that are spontaneous.
They are spontaneous.
So
okay.
the IUGR baby is going to be delivered by the clinician.
They've made a decision.
They made a decision to get this baby out as they feel it's going to be better out than in.
Mm-hmm.
And the spontaneous preterm baby, somebody else making a decision, say, I need to come out. Yes.
So would you define then what is, because again, there's lots of numbers that are thrown around. 40 weeks is a, full-term pregnancy, but it's also can be 37, and therefore under 37 is potentially preterm. So just for the record, what would be considered a preterm delivery in terms of weeks of gestation?
Absolutely. Some landmark dates, 37 weeks onwards, you consider to be term.
Okay.
So 37 weeks and 1 day, you're not preterm anymore.
Okay.
You are a term pregnancy.
Baby,
yeah. Before 37 weeks, you are preterm.
Okay.
Now, there is preterm and preterm. So you have what we call late preterm babies. These are usually after 33, 34 weeks. Yeah?
Okay.
And if you were to look as to who goes to neonatal unit because of gestation, usually babies below 35 weeks, you will find different limits with different hospitals, but in general, below 35 weeks, they will go almost automatically to neonatal unit. Below 33 weeks, you have kind of preterm delivery that is more concerning, and between 24 to 28 weeks is what we call extreme preterm labor. Before 24 weeks is effectively considered a miscarriage. Yeah. Now, obviously, these things are continuous rather than
hard
stops from one to the other. But when we do, just to put some significance to different gestational ages, when we talk about moms who are at risk for preterm labor, we say, all right, our first landmark is 28 weeks. Why? because 28 weeks, it's a time that you expect roughly about 95 to 97% of well-grown babies to survive. So you have very good survival chances. And we're talking about delivering in a setting with a good neonatal unit, which again, talking about Dubai, it's good for mothers that they deem themselves to be in a higher risk for preterm labor, to make sure that the place that they are delivering in can look after a preterm baby.
Yeah.
The next level is 32 weeks. 32 weeks survival is fantastic. It's almost as good as a full-term pregnancy. However, a 32-weeker may well spend just under a month in neonatal unit. So the real time that you send mom dancing and we have a party is around 35, 36 weeks.
Okay.
Because those babies, you expect them to be with mom. Yeah. So they have a higher chance that they don't need the NICU. They're still more needy babies.
It's more vulnerable.
More vulnerable. But the majority of them will be with the mother.
That's very, very, very important to have actually broken those down in weeks, because it's definitely something that women worry all the time, even at low risk, because as you said, a lot of the times, preterm deliveries are spontaneous.
Actually, most of the times.
Why is that?
Yeah.
That was my next question.
We don't have an exact answer. There are different factors that can play into why preterm labor is happening. You can find risk factors from the history. Okay. Let's say a mother had a preterm labor before. So this by default puts you on a high risk of repeating yourself. A mother had an operation at her cervix. The cervix is basically what keeps the baby in. If you use your imagination and think your uterus like a balloon, the cervix is the neck of the balloon, is what holds the baby inside. On occasions, operations that happen in the past because they were worried about cervical changes can weaken the cervix. The load of the uterus, how much you blow that balloon up. Typical example, twin pregnancies.
That was another question. Yeah,
so
multiple.
You have bigger uterus, more stress to the uterus. Anything that irritates that balloon.
Yeah, of course. Yeah.
Typically, urine infections. The bladder is a close relative to your uterus. That's why when you go and you do your routine testing,
you always have
they will always ask you to give a wee sample. And that's why your obstetrician is going to be giving you antibiotics for little things. There's just been a few bugs in the urine. Yeah. I say, well, when I was in pregnancy, I just had some cranberry juice and a lot of water, which is fine. Yeah. But because of the worries for preterm labor and certain other worries about how these infections behave, your obstetrician is going to be more likely to treat a urinary infection. So different reasons. The next step is, well, George, if you don't know who's going to go into preterm labor, what can you do about it?
That's it. Yeah? That is my next question. What are the causes?
How can you prevent? Well, one is being alert.
Okay.
Yeah. But if you look on the medical part, recently it has become clear that looking or monitoring cervical length can identify to some degree a group of mothers that are at higher risk of preterm labor. So in many settings, it's become a routine. Usually, I'm assuming that you are a low-risk mom, that there wasn't anything from your history to make the team be worried before. Yeah. Usually at around the 20 weeks mark, to do a scan to measure the cervix. Now, there is a catch with it, that this scan is normally an internal scan. So not everybody feels particularly comfortable about it. But once you have the opportunity to have that discussion with the mother, most of the mothers will accept it. And slowly it's becoming an accepted practice. And then when it's becoming an accepted practice and everybody's expecting it, and then it's not such a big deal, to measure the cervix at around 20 weeks. You will say, George, do I feel anything different as a woman that I need to call my obstetrician?
Well, this is it. Any signs and symptoms?
So 3 big groups of subtle signs that you need to be aware. Sudden changes of your discharge.
Okay.
So sometimes, and again, visualizing the changes might make it easier to understand. A woman who's pregnant always has more discharge than usual. Yeah. If you think the neck of the womb being like a tube, when it's open it up, it exposes the membranes.
That's right.
Yeah. So normally at that point, women experience much more watery discharge that they say, oh, this is different. Yeah? A lot of pressure. You feel pressure at the top of your vagina that feels different.
Yeah.
Contractions. They may not be the labor contractions, but you feel more activity than usual. A lot of tightenings that come one after the other. Now, all of these are non-specific. And I have to say, the majority of times, everything is absolutely fine. However, again, it's important to have a link with your caring physician, because you can only say that it's fine after you checked.
Correct.
Yeah. And again, that's the beauty of private practice. You can reach us. Yeah. You can pick up the phone and say, I'm worried.
Something's not right.
And I always say to my mothers, because they're always very good at picking up the phone or the WhatsApp, we cannot.
I think I did it once too with my second.
We cannot do medicine over the telephone.
Yes.
Yeah. The telephone is alerting. Yeah. You need to be seen. You need to be examined. A lot of times the pregnant mother or any patient will seek reassurance.
A quick reassurance over the phone.
A quick reassurance. The honest answer is we cannot, because we don't know. We haven't examined you. We haven't checked you. Yeah. So what you should be expecting is just a triad call. Yes, go to the hospital now. Come to the clinic now. Or maybe we can wait till the morning. We'll see you in the morning. Yeah. This is the kind of interaction that you would expect. More like
a little bit more of an emergency or something that can be seen the next day. Yeah. In terms of, so if you have a woman who is presenting with potential early labor, are there treatment options to maybe, if she was in a pretty, you don't want to, let's say she's about 29 weeks or 30 weeks. Are there treatment options to try to delay that or postpone that?
The answer is absolutely yes.
Okay.
They're not brilliant, but there are treatment options to try and settle things. And the earlier you present, the more likely for those to be effective. All these treatment options are in-hospital options.
Okay.
Yeah. So again, going a step back, it is important to identify the problem early. Yeah. So it's okay to have a false alarm. So you are coming into the hospital. There are medications that can be used for a short period of time to slow down contractions. There are actions that the clinician can take to prepare the baby, if it is to be born, to have a smoother course outside the uterus, typically giving steroids to prepare baby's lungs, sometimes magnesium sulfate to protect baby's brain. So there are actions, and this is where our tocolytics work. They're giving us a window of 24, 48 hours to take those actions.
Okay.
Now, sometimes after you do that, the initial cause has subsided. It was an infection, it was an irritation, something, and things kind of slow down and smooth, and they keep on. No, sometimes they don't, but it is important to get those early steps in.
That's right. In terms of preterm, I mean, what are major complications that can result in preterm deliveries? I guess for a little bit from mom and a bit for baby. I know with the baby there, obviously in terms of growth and development and obviously an ICU stay, but what are the major risk factors that are associated?
Well, it very much depends on the timing, because different times have different implications.
Risks,
if you remember what we said,
the very early
28, 32 weeks. For the mother, catching the mother first, medical actions, so more likely to be in hospital, have antibiotics, have things done to you, on occasion having to do operations like cesarean sections to deliver the baby. A big part for the mother is the psychological impact, because having a difficult delivery or a difficult post-delivery course with your baby, effectively, it's like going through post-traumatic stress disorder.
Yeah.
It is trauma.
Yeah.
So these are the parts for the mother predominantly, basically interventions from the medical team, and whatever this would be a difficult delivery, and also the psychological and stressful part kind of moving on. And important, but kind of not on the same part for the family, the financial burden of kind of a preterm baby and the care of a preterm baby.
In an NICU setting.
In an NICU, but this might not be just NICU, because talking about the baby, some little ones will have long-term problems, whether this is how you develop your lungs. But the part of our body that develops last tends to be our brain. So having the nice, quiescent environment of the uterus disturbed, despite the efforts of the neonatal units to make it more baby-friendly, kind of quiet, nice environment, is not the mom's uterus, So how you develop afterwards does have a major impact. Being in an intensive care setting and being vulnerable, which are the two things that a preterm, premature baby is, exposes you to other problems, because you might be born perfectly fine and then you catch up a major infection. How you deal with it, what does effect this have? So developmental issues, and we can go to major neurological problems or even losing a baby. All these things can happen with preterm labor, and the frequency of this happening depends on the gestation from one part, and depends on who you are if you were to link it with a growth retardation before. So you have a different outcome, let's say, for a 30-weeker that it's appropriately grown and it's had a preterm baby, and different outcome for a 30-weeker that it's been delivered because it's
IUGR.
been severely growth retarded, and it's born at 30 weeks.
I got you. There's a lot to consider.
You guide me to the things that are relevant. A lot of it is medical.
No, but this is, I think, from a parent point of view, it's causes, treatment, why, what is the I guess moving forward after a preterm or IUGR. I think these are the concerns always when it comes to patients. And it's I think, to sort of sum it up, the most important thing is to have that touch point with whoever's looking after you. sitting down, really understanding what is the course of action and what is going to be the plan. Because at the end of the day, you can potentially be prepared and the best outcome will be kind of devised for that situation.
You're spot on again on that. Because where the clinician works, he works in, or she works in different levels. So it's the connecting link. So part of it is dealing with the parents, dealing with your anxieties, setting up a plan forward. But on the other end is linking the follow-on. So getting the mum to see the NICU, getting the mum or the parents introduced to the neonatology team, bringing in the hospital support. Kind of, do you need to see the anesthetist? Do you have more medical problems that need to be dealt with? Setting up the stage for afterwards. This is where midwives are extremely
Crucial.
Yeah. And again, yourself being a mother, you will see you have different levels. You speak different to your doctor.
Correct.
You have a different level of connection with the midwife who is sitting next to you.
That's right.
Like
Holding
a big
your hand
sister,
through it. Absolutely.
like a mother that you can open at a different stage. Sometimes the doctor comes, delivers, goes. Then you're left with a little one that needs to breastfeed, that needs care.
Absolutely.
And the doctor looks at you with a very blank face because he or she doesn't know, supposedly have done the job.
Yes.
But the job is not done.
Yeah.
Kind of bringing around you or any mother the right team
and support
people,
structure.
Support, and then debriefing afterwards. So
such a strong point, debriefing afterwards. Yeah.
Kind of putting things together when the emotions
die
down a little bit. So going through and setting a plan for the future. Hopefully that helps with the mental part as well.
I was going to say, I think it's got to do a lot with the mental health moving forward, to be able to have the facts in front of you and your team in front of you and go through it. There's nothing worse than having things not explained and you not knowing what had happened or what had gone wrong.
It would be fantastic to be able to give answers to all of this, but on occasions,
you don't have.
The
but
admission,
that's the
admission that
Absolutely.
we don't have an answer, and just being honest and upfront about it, it's the only thing that you can do.
Absolutely.
And kind of move on from there.
Yeah. I have to ask because there's a lot of people that will probably want me to ask, but in terms of multiples, multiple pregnancies, again, are quite famous for being, or twins are quite famous for being delivered or having early deliveries. Is that almost, let's say we were taking it as a percentage.
100%.
Is it? Okay.
And again, depends where you put the definition. So the average gestational age for twin delivery is around week 36, which by definition is preterm. The average age for a triplet delivery is around 33, 34 weeks.
That's the average age.
That's the average age.
Good. Yeah.
From the clinical point of view, the clinician will not allow or should not allow a twin pregnancy to go over 38 weeks. So most twin pregnancies will deliver on that limit between 36 to 37 and a half weeks. And believe me, most moms by that stage
are done.
They're done. They want to be delivered. Yeah.
Can I ask, is that because obviously, is it just the efficiency of the placenta past a certain point? Okay.
Exactly. There is a higher risk of loss and problems after 38 weeks with twin pregnancies. And efficiency of placenta is something that is very important. It links with the IUGR and everything that we said. Also, it links with gestation of delivery. Yeah. A common statement for the mothers is, whenever my baby is ready. Well, it doesn't work like that. And there's now ample evidence that as you go over 40 weeks, the risk for significant problems with the little one increase dramatically. And it all has to do with that mismatch of need and provision. So the baby is growing, it's bigger, it needs more oxygen, it needs more energy, while at the same time the placenta is starting closing down. And a lot of people say, do you mean, George, it's going to be a bigger baby? I won't be able to push it out. And I say, no, it has nothing to do with the size. It has to do with how well the baby is, how well the placenta is functioning. So although the traditional NHS type approach was to allow pregnancies to go 41, even 42 weeks, things have moved significantly that now the recommendations are around the 40 weeks mark for a mother to deliver. Even the Americans went a step further and say that at 39 weeks, you should be offering to mothers the option of induction.
Yeah.
So these are subjects that need to be discussed and understood from the parents. The problems that we have as clinicians, because the mothers come, they have the ultrasound scan, say the baby's fantastic, say, all right, George, baby's fantastic. Why do you want to get it out? Yeah.
I'm fine now. I've got another one at home. I can't deal with the two.
But the thing is that our tools for monitoring a baby at full term, they're just not good. They're all devised and developed to look after that IUGR baby and try and see when should we get it out before we lose it. This doesn't apply for a 39-weeker, for a 40-weeker. Our tools are extremely blunt. Also, the babies are more sensitive because these are well-grown, chubby little ones that are used to be fed well from the placenta. So if you suddenly drop that flow, they get unwell very quickly.
Distressing. Yeah. It's good to know. It's good to know. Again, these types of conversations should be had. I think I'm sure it's case by case basis. Every pregnancy is different. Every mother is different. Every baby is different. And it's almost just hammering the point of have that points of connection, whoever's looking out for you, to talk about what the options are, to really feel quite confident in the course of action, whether it is multiple pregnancies, whether it's IGR, whether it's potential, early delivery or a low risk pregnancy.
Ask questions. And feel that your questions are acknowledged and answered. Yeah. This is where Google plays to some degree a role. The difficulty in general with Google or advice that you get over forums, this is what happened with my baby, this is what happened in that case, or don't worry, is that the advisor, one, doesn't know your case, two, has no responsibility for what you do.
Absolutely.
Yeah? So you need to do all these things that I read about actually apply to my case?
Yeah.
Is there another option? Why is my doctor worried? Yeah. Why is he or she suggesting something that is not in line with what I thought would be the best? Because there's no mother that makes choices that she doesn't strongly believe are the best for their baby and herself. Yeah. Even choices that may not be right. For the mother, the choice comes, this is what I firmly believe is best for the baby. Yeah. Then it comes to the obstetrician to try and break it down and hopefully create that connection to pass the message that for this and this and this reason, I don't think that this is the right approach. Yeah.
I could talk about this for hours and hours.
We can be here forever.
Really can be here forever. I guess sort of the final takeaway, what advice would you give expectant parents, pregnant mothers at this point, that are maybe facing a high risk situation, whether that's IUGR or have, maybe have had a preterm delivery? Any sort of take home as to how to manage a situation that they might be finding quite difficult?
If you have the option, gather the right team around you. Create that circle of professionals that you feel confident looking after them, looking after you and your baby. Because especially in those difficult scenarios, at some point, you just have to pass the ball to them and say, tell me what I need to do.
Yeah.
And I will do it.
Yeah.
Yeah. I think that's the main thing. Feel comfortable and confident about your team. Create that team around you. Feel confident that your caring physician is providing these things for you. It's giving you the time, giving you the answers, delivering you in the appropriate hospital. Yeah. Meeting the right people in the hospital and feeling confident that, yes, this is a right place that I want to deliver. Yeah. This applies for the private care. For the government care, it all comes to the government to set the standards and say, yes, well, we will create the teams and we will offer to our mothers the right pathway to follow. Yeah. So there is a distinction there.
Okay.
But I think for the group of mothers that usually we refer to, it's going to be private care clients, mothers. Yeah. So they just need to find the team that they feel comfortable with.
Brilliant. Dr. George, I have to keep bringing you back here. I feel like I still have so many questions.
I would be delighted to come and talk.
I'm going to keep knocking at your door to do another interview. Thank you so much. Thank you for this. This was so informative. And to be honest, I always think to myself when I was first pregnant, preterm deliveries and, pregnancy is a wonderful time, but it is a time where there's so much that's out of your hands. And again, I think you mentioned for women, especially in this generation where they're quite A-type and everything is project-based, pregnancy seems to throw everybody off a little bit. It's the loss of control. You don't know what's going on and you just kind of have to go with it. So to be able to have things broken down in a way that's not as intimidating. And to be honest, I felt it was quite positive. I'm really appreciative.
No, listen, pregnancy is a wonderful thing.
Yes.
I think for myself as being a mom, I feel privileged to be able to see what a mother is able to create. Yeah. So we all, from the man's point of view, should be admiring you. Yeah.
They should be. Did you hear that, everybody?
Yes. Yeah. No, that's a big quote there. Yeah.
Absolutely.
Because the vast majority of mothers have wonderful pregnancies. Yes. Yeah. And it is, again, it is a very positive experience. It has its challenges, but wow, at the end, what is the prize?
Absolutely.
Yeah?
Absolutely.
You cannot compare it with anything else. So embrace it and create, for those of you that need more information, the right team to satisfy the anxiety. And then it goes to the clinician to distill out from your history whether you are different steps. A lot of time mothers ask, am I high risk? You're a wonderful mother. It doesn't matter. It's not high risk is a label. Yeah.
Thank you for saying that. Yeah. It's a scary label.
It is. it is a meaningless labor. Yeah, it doesn't mean anything. The clinician needs to sit down and make a plan that applies to you, and be able to work with you to adapt the plan depending what the pregnancy throws.
Absolutely.
If everything is going fine, take a step back, leave you alone, do your thing. You want to do bungee jumping?
That's up
enjoy.
To you.
But if things are changing,
Yes.
kind of put the restrictions that are needed. Yeah.
Thank you so much, Dr. George. Thank you for your time. I am forever grateful.
It's been a pleasure.
Thank you.
Thank you for listening to They Say It Takes a Village. I hope you enjoyed today's episode. I look forward to bringing you another one next week. Don't forget, please subscribe, rate, and review so I can reach and help even more parents. And if you've got a topic that you'd like me to cover, please head over to my Instagram page, ittakesavillage.me, and drop me a line.